You can go ahead.
Okay, thanks. Okay, welcome everybody to this session of GECO, the Fellows Meeting, which of course is hosted by the Gastro Foundation in association with Project ECHO, University of New Mexico, and it's run, of course, every second Monday at 1800 hours. After the talk, the chat will be open for questions, even better, given that this is meant to be a more informal session. Please ask the questions in person. So today our presenter is Dr. Midhun. He's a fellow up at Charlotte in Gauteng, and the topic that he's going to cover is conventional drugs in IBD. So if you can please share your screen and let's get started.
Sure, thanks, Prof. Let me just share the screen.
Perfect.
Prof, I just want to confirm, can you see the presenter view or just a
No, I can
normal?
see the presenter view. It's perfect, so you can carry on.
Excellent. All right. So good afternoon, everyone. My name is Midhun, as Prof was saying, and I work in Joburg Gen here in Johannesburg. And today we'll be covering quite an important topic. I've done complementary therapy in IBD. Pascal's going to do advanced. So today, to start it off, I'm going to be doing conventional therapy in IBD. So a lot of my talk is essentially going to be focused around these particular drugs, your aminosalicylates, your glucocorticoids, and your immunomodulators. So much of my time and much of what you'll see as a conventional therapy revolves around these particular drugs. But the general principle for IBD, essentially, you would find in all our guidelines, ECHO, BSG, essentially revolves around endoscopic healing, clinical response, biochemical response, as well as radiological and transmural healing. So you'll find that essentially all of our treatment, whether conventional, advanced, complementary, all target essentially these four domains. So without further ado, I'm going to start off with our first drug. Just to let everyone know, a lot of this information does come from a backbone of Schlesinger as well as a combination of BSG and a couple of articles. So you may find that some of the slides are referenced, whereas some are not, because it does come from our main prescribed textbook. So the first one is our aminosalicylates. So aminosalicylates, essentially the parent compound being sulfasalazine. When I tried to look at the history of most of the drugs, I found that this was essentially developed by a lady by the name of Nana Swartz. She was a Swedish physician, and in the 30s or 1930s, essentially, she used sulfasalazine as a treatment for rheumatoid arthritis. What's interesting about her is that she essentially was the first female professor at her university or in the public universities in Sweden, and a lot of her research was focused on GI diseases as well as rheumatology. The association of sulfasalazine and its role in GI was essentially found a couple of years later in 1941 and 1942. So essentially, they found that as soon as they put patients on treatment for their arthropathies, a lot of their symptoms of diarrhea suddenly improved. And with that association, a lot more discoveries came with the drug. Sulfasalazine essentially does comprise of two components. One, the 5-aminosalicylate component, and the other being the sulfapyridine, as you can see in the diagram at the bottom. The bottom left picture is essentially a picture of the Swedish physician, which was really difficult to find a clearer picture than this. But the one on the right essentially is the chemical composition of sulfasalazine. The reason why I put it there is because at this stage in the 1940s, they were treating these patients with sulfasalazine, but they found that there were a few adverse reactions that took place. And at this point, they weren't really sure what really was the active compound or active metabolite. Was it the 5-aminosalicylate or was it the sulfapyridine? And so in 1977, almost about 30 odd years later, a gentleman by the name of Dr. Zad Khan basically went through a classic experiment that essentially revealed to them that the active metabolite was indeed the 5 ASN and not really the sulfapyridine component of it. And what they found is that 90% was absorbed in the colon and a small amount was absorbed in the small intestine. So what happened is that once the drug reached the colon or the small bowel, essentially there was an enzyme called azoreductase from our anaerobic bacteria in the colon that essentially cleaved this azo bond and essentially left you with the 5-ASA. And what 5-ASA did was that it acted topically on the colon as well as some being absorbed. So there are other drugs similar to the sulfasalazine being also I practice this hard, ulfasalazine and balsasalazide, which essentially had these azobond linkages as well. Um, what we notice is that sulfasalazine, like I mentioned, from the sulfapyridine point of view, puts you in a high risk of adverse reactions or adverse events, being fever, rash, nausea, vomiting, and diarrhea. And other sort of problems such as hypersensitivity reactions, as well as sperm abnormalities and impaired folate absorption. So when patients are on sulfasalazine, it's important to think of your folate supplementation. And this diagram essentially is the chemical sort of breakdown of what also salazine and balsalazide looks like in a chemical sort of schematic presentation. And so, with the discovery of this azo bond linkage with sulfapyridine, essentially further research had gone into then saying, hey, how about getting this alone without the azo bond linkage? And that bore innovation to our four drugs that we commonly see. Number one being pentasa. So, pentasa essentially has and methyl cellulose coated microgranules. And what it essentially does is that it releases the mesalamine from the duodenum throughout the small intestine as well as the colon. So 50% essentially releases in the small intestine and the remainder in the colon. Another drug called aprezo essentially also delayed release in the because of this enteric coating that they have. And how a preso works is that it works on a pH based system. So if you have a pH, which usually in the terminal ileum of more than or equal to 6, it releases there as and then subsequently throughout the colon. Asacol. Recently, we had major national shortages. This Asacol essentially has something called Udraget S100, and it's also coated in a similar way that at the pH of more than or equal to 7, usually in the distal ileum, it releases and subsequently spreads into the colon. What's nice about Asacol is that not a lot of it is used in the small intestine, and majority does go into your colon. As you can see, 15 to 30% is released in the ileum. Then another drug called Lilda, which is essentially novel, but it essentially works on a inner lipophilic matrix and an outer hydrophilic matrix. But the concept is that it essentially releases slowly, giving you more active metabolite in the colon where it is needed. And so in Schlesinger, this is summarized essentially in a nice table, talking to the site of delivery, talking to essentially the mechanism behind it is delivered and the formulation. So you can see the prodrugs being your sulfasalazine, and then your mesalamine preparations being the ones that we use, our Asacol, your Pentasa, and what have you. So what does this mean in Crohn's disease? So what I'm going to be doing with all of the drugs is essentially telling you what is the role in Crohn's and what is the role in ulcerative colitis. So in Crohn's disease, with aminosalicylates, there is limited data supporting the role of it. Most studies show that sulfasalazine to be superior to placebo, inducing remission in active Crohn's disease when the colon is the primary site affected. There are a couple of studies that were done trying to elicit what the efficacious dose of aminosalicylates are, and I came across two studies, essentially the National Cooperative Crohn's Disease Study, which is the NCCDS, which looked at 4 to 6 grams per day, and the European Cooperative Crohn's Disease Study, which basically looked at 3 grams per day, but essentially they provided no benefit really in achieving remission. There are early studies that looked at Pentasa less than 2 grams a day, which basically failed to show efficacy in treatment of mild to moderately active Crohn's disease. But at the end of the day, in our current recent guideline, BSG 2025, it really wasn't recommended for induction and maintenance. And then the conclusion essentially is that it's not really added into our evidence-based treatment algorithms. However, this should be decided on a case by case with obvious experts in the field. Then the role of ulcerative colitis. It has been shown aminosalicylates to be efficacious for induction and maintenance of remission in your mild and moderate to active use, moderately active UC. Doses of 3 to 6 grams per day essentially has shown to induce remission in about a range of 39 to 62% of patients, which essentially means that it's almost double the remission rate of placebos. Multiple Cochrane reviews have showed that the induction and remission of patients in a large sort of review of 53 studies with around 8,000 patients show that 29% of patients on aminosalicylates entered clinical remission compared to your placebo 17. There were studies that tried to look at whether BD dosing versus TDS dosing is better to the daily, but no real difference came about from that. So whether you take it daily, BD or TDS, showed that the effect was equal. So with a lot of IBD and a lot of treatment throughout GIT, there are a lot of trials. So I just mentioned these few trials. So the Ascend 1 and Ascend 2 trials. But essentially they showed what they tried to find is the correct dose, the accurate sort of dose or good dose essentially for mesalamine to be prescribed at. And what Ascend 1 and 2 did is they looked at 2.4 grams to 4.8 grams daily. And essentially it showed similar effect with 2.4, 4.8 in patients with mild disease, but 4.8 grams per day were needed in patients with moderately active disease to achieve a high response. This then was built further on with the Ascend 3 trials and the Lilda trials, which basically showed that actually 4.8 grams daily was actually better than 2.4 grams daily in patients who were previously on mesalamines or those with no clinical remission in 8 weeks. So essentially, it's just showing the importance of the dose, especially when exposed to mesalamines previously or obviously not getting better. And then the momentum trial related to aminosalicylates and UC basically showed that in mild to moderate active UC, patients who achieved complete remission after 8 weeks of therapy with 4.8 grams of mesalamine were actually more likely to remain in remission with dose reduction to 2.4 grams. So there's a nice sort of guide as to see where you can go in order to make sure that patients do not relapse. So these are nice important trials to think and remember with regards to aminosalicylates and ulcerative colitis, excuse me. So what does BSG say, the recent guidelines say? So essentially, it basically backs the fact that proctitis can be treated with topical 5-aminosalicylates, which I'll talk about in the next slide. But if there is no response, then you can add your oral aminosalicylate or topical corticosteroids. Entry treatment for mild to moderate UC would be your aminosalicylates. In terms of the dose, though we've spoken about it now, 5-aminosalicylates of more than or equal to 2 grams per day should be required for induction and maintenance of remission. Not a lot of large RCT studies have been backing up the 3 to 4.8, but clinically, if patients have severe disease or no response, then to go up, as we saw with our momentum trial. And combination of oral and topical therapy has been shown to be better in terms of clinical remission and clinical response. So BSG essentially speaks to aminosalicylates being quite useful for the disease. Now, with rectally administered therapies, there are three main formulations that are found. You've got your enemas, your suppositories, as well as foam. So, what's important to know is that when one gives these rectally administered therapy, it can go about to the spleen flexure in about 95% of the patients. But the number that I eventually got was that from the anal verge, it can go about 15 to 20 centimeters up. So this is important to know, especially once you've scoped patients and you can see how bad the disease is. It can guide you as to how what you can treat these patients with. So if you know that it's past 20 centimeters or it's more left or right sided, then obviously you can decide accordingly. So with patients with ulcerative proctitis or left-sided disease, you can use it, and also with adjuncts to your oral therapy, it is useful as well. So the standard dose essentially is about 1 to 4 grams of aminosalicylate enema per night, or the suppository being 1 to 1.5 grams daily, or with divided doses. The rectally administered aminosalicylates are preferred over your topical glucocorticoids and distal UC. However, it is most effective when it is combined with your oral mesalamines at the end of the day. So this is aminosalicylates essentially for IBD. So the next important drug is our glucocorticoids, and we use this quite often, not just for IBD, but for many, many conditions throughout medicine. We do know that it is effective, and it can give you rapid induction, as we've seen in a lot of the talks that we've had before with acute severe UC and in many other circumstances. So it can rapidly show clinical improvement. However, having said that, prolonged use and repeated use leads to its adverse events. And we all know that there's multiple side effects for our glucocorticoids. So using this on a long-term basis is very dangerous. Your infectious risk also is increased at higher doses of more than 60 milligrams daily. And like I said, not recommended for long-term use. Budesonide is quite a nice drug in that it has a high hepatic first pass metabolism, which therefore puts you at a lower risk of developing systemic adverse events, and which is why it is quite appealing. However, not as available as your conventional glucocorticoids. So the principles for glucocorticoids essentially are the four main things. The use and effective dose that one must think about is between 40 and 60 milligrams daily. It is taught that it's 1 milligram per day, milligram per kilo daily. However, overdosing the patients, or rather going over 60 milligrams per day, has shown to not really have much benefit. So going more than 60 milligrams per day really is not advised and just puts you at high risk of developing adverse events, as we've mentioned already, not to treat for a long period of time, and also when using glucocorticoids to always anticipate the side effects. So we'll talk about the adjuncts that you can give, but always think about it. And we do write that your calcium replacements, your PPIs, and what have you, or vitamin D, we need to think about whenever prescribing the glucocorticoids. Sorry that it's a lot on one slide, but I find that a lot of these presentations, a lot of people study from it. So it would be criminal of me just to put a line and not put information, which is why it's a bit busy. But I'm going to try to talk through it so there's not too much. But with regards to glucocorticoids and Crohn's disease, as we spoke about before with the NCCDS and the ECCDS, essentially they've spoken about it being favorable in the short term. And the dose that NCCDS came about with was 0.5 to 0.75 milligrams per kilo per day for the initial treatment, with dose adjustment depending on the clinical response or clinical disease activity rather. ECCDS took another approach in that they said use it for short term, but rather let's do 48 milligrams per day in the first week, and you taper by 12 milligrams. So by to 12 milligrams by week 6, and then you keep it at 8 milligrams for remission for up to 2 years. Now, the issue with that is 2 years with steroids, as one can imagine, is a little bit of a dangerous thing. But usually in patients with mild to moderately active disease, you try treat with initially 40 to 60 milligrams of prednisone and then taper it over 6 to 12 weeks. Studies have found that essentially the response rate is around 80% by the end of the first month, which shows how quickly and great it acts, especially in the beginning. So when they found that doses were pushed to 1 milligram per kilo per day as opposed to zero point 0.5 and 0.75 for about 7 weeks, 92% of patients achieved clinical remission. However, for long-term therapy with all of its side effects and the potential of glucocorticoid dependence, it was a bit dangerous and also not advised. Then comes the budesonide, which we touched on earlier on. It is structurally different from prednisone. 90% undergo first pass metabolism, and it is essentially converted to metabolites that have little biologic activity, which means that there's less systemic bioavailability, creating less toxicity. So budesonide can be seen as Entocort. This is the preparation that we have, and essentially Entocort has this controlled ileal release of oral budesonide preparation with this udrigate L100 coated microgranules as well with an internal ethyl cellulose component. But what this all means is that it releases at a pH of more than 5.5 and about 50 to 80% is absorbed in the ileocecal region. There are studies that show that a dose of 9 milligrams is far superior or superior to placebo and mesalamine and 15% less effective than prednisolone in achieving remission. However, even though it is less effective than prednisolone, there are fewer side effects for these patients. There are RCTs or randomized control trials that compared the 6 milligram to the 9 milligram at 12 months, and they found that there was, excuse me, a lower relapse rate of the 9 milligrams in comparison to the 6 milligrams. There are also meta-analysis that essentially showed that active luminal Crohn's disease was superior over placebo-inducing remission, but not in preventing relapse with Entocort. But essentially, overall, the use of glucocorticoid steroids is usually in the setting of induction with essentially an immunomodulator or biologic agent, but rather not to use more than 12 weeks for its significant side effect profile. So I got stuck. So then essentially this image is from our BSG guideline, which basically speaks to what we spoke about now. So in the setting of ulcerative colitis, same goes with 40 to 60 milligrams per day in the use of moderate to severe UC. Budesonide has been shown also for or useful for the induction of remission where especially aminosalicylates have failed or not tolerated. And to also avoid adverse events or side effects from normal prednisone. Higher doses associated with adverse events, as one can imagine, but with no significant benefit, which is why we say not over 60 milligrams per day. There are not many studies that essentially compare oral to parenteral. However, as you know, with our acute severe UCs, we use our IV formulations initially, and it's shown to essentially help a lot of our patients. There are double-blind studies that Schlesinger spoke about, which compared at looking at continuous infusions in comparison to divided doses, and it was found that there was no benefit in doing continuous infusions as opposed to the divided doses that we do. In terms of maintenance, not much benefit, especially outweighed by the side effects. In UC, rectally administered glucocorticoids come in liquid and foam formulations, and it's quite effective for your short-term therapy for active ulcerative colitis, especially distal disease that extends to about the splenic flexure. It is said that foam is easier to retain and it is tolerated better than actually the liquid form. And then that with topical mesalamine has been shown to be very effective together, especially in treating the distal UC. So, with ulcerative colitis, prednisone is recommended, as we've now summarized. However, there's a lack of trial data, but essentially, the optimal dose that was spoken about in BSG is essentially 40 milligrams with a dose reduction of 5 milligram per week, essentially to zero, with the addition of our immunomodulators on top of it or advanced therapy. The once daily dose recommendation is spoken about, and rather take it in the morning with food to prevent one, your sleep disturbance, as well as dyspepsia that one can develop without calcium and vitamin D, unless it's contraindicated, is what you need to add as an adjunct to our steroids. Concomitant use of PPIs for the dyspepsia. However, there were things I've read recently that PPIs we don't usually put upfront with steroids, which I thought was the case, but beclomethasone, dipropiate, and MMX is also suggested for the induction of remission in patients with UC where 5-aminosalicylates had failed or not tolerate. And when you're trying to avoid the side effects. So that's essentially just a summary of what BSG 2025 has said now about glucocorticoids and ulcerative colitis. So now we've completed aminosalicylates, glucocorticoids, and now we move on to thiopurines, our immunomodulators. So just a background on thiopurines. First, it was brought about in 1951 by Elian and Hitching. Essentially, it was used in the background of cytotoxic and immunosuppressive effect. So Elian and Hitching were Nobel Prize winners for their contributions in drug development. I did not know this, but essentially they were very well known for developing drugs for leukemia, for gout, immunosuppression, like in the case of thiopurine, as well as zidovudine, so AZT, one of the first HIV drugs back then, as well as acyclovir. So they've actually done quite a lot of research and brought a lot of drugs to us to use today. So I thought I'd mention them. And then in the 1960s, Brooke and Bowen then saw that thiopurines were effective in refractory IBD patients. Then in 1980, then they compared this to placebo-controlled trials, and they found that thiopurines showed superiority in induction and maintenance of remission. And then in 1993, they put this all to the test and they look at a 20-year clinical trial and basically showed that there was 60% of patients on thiopurine therapy were steroid-free in remission. So we use thiopurines quite a lot, and as an immunomodulator, we've probably commonly known them as azathioprine as well as 6-mercaptopurine. And essentially, they are purine analogs that interfere with your nucleic acid metabolism and cell growth, which then essentially causes a cytotoxic effect on lymphoid cells. So this schematic is quite important because it helps you to understand the pathway of which thiopurines are metabolized and what drugs one should look out for or use in the use of these particular drugs particular drugs. So essentially, azathioprine is known to be the prodrug, and what it does is that it is metabolized to 6-mercaptopurine with the help of, it's not on the diagram, but glutathione S transferase. And essentially, this 6-mercaptopurine goes into three pathways. Essentially, with the help of xanthine oxidase, as you can see in the schematic, becomes thiuric acid. And with the help of TPMT, it goes into 6-MMP. As well, you can see that at the bottom as well. So what does this all mean? So essentially, these are all active metabolites that assist in the function of the actual drug. But what one can note is that when you have higher levels of 6-TGN, so essentially the bottom left, higher levels of your active metabolite being 6-TGM, it's actually linked to myelotoxicity, so bone marrow suppression. So doses that have created high levels, if you measure it, of more than 450, are associated with the increased risk of leukopenia. However, conversely, levels within an optimal range of 230 to 400 of this metabolite shows you essentially a therapeutic effect. Then with 6-MMP, high levels of this metabolite are associated with hepatotoxicity, with ranges of the active measurement being more than 5,700. And measurements of that essentially say that you're at high risk of developing this hepatotoxicity. As you can see with allopurinol, there is some effect of it. Essentially, it works on your xanthine oxidase and it essentially increases your metabolites, especially in the setting of no or not much effect of your thiopurines. So it can be used concomitantly. However, close monitoring needs to be done when using this, and not really advising people that are not trained to essentially see the effects and monitor properly. So thiopurine, essentially as a monotherapy, is not really recommended due to its low set of onset of action. So what is recommended is that you use it in induction of remission with faster acting efficacious drugs like our glucocorticosteroids that we spoke about. One can imagine with our diagram that I showed before, it's important to always check TPMT. Now, in Schlesinger, they've spoken about recent associations of Asian ancestry with NUD or NUD15 genetic polymorphisms, which essentially can put you at a high risk of developing myelosuppression with your 6 TGNs as well. The considerations that one must have when starting patients on thiopurines is that patients who are corticosteroid dependent patients can be used are to be considered postoperative prophylaxis or Crohn's disease, recurrent patients, maintenance strategy for patients who have been on cyclosporin after an acute severe ulcerative colitis event and rescue therapy can be bridged over to thiopurines, and then obviously concomitant immunosuppression during advanced therapies like biologic therapy. So thiopurines in these four instances can be effectively used as well. When thinking about the dosage, the standard dosage is 2 to 2.5 milligrams per kilo a day, and the steady state, like we mentioned, is a bit longer, so it takes about 14 days, and that's why it needs to be used without glucocorticoids. Therapeutic drug monitoring, according to Schlesinger, is recommended. However, obviously, the availability of being able to do this is quite limited in a lot of our settings. So therefore, the least is at least to do your TPMT before starting patients on treatment, and aiming to essentially identify once you've got the result for TPMT, whether you can go up and down on the drug dose. Adverse reactions to thiopurines are usually said to be rare, however, obviously can happen. As we've gone through already, there's the myelosuppression, hepatotoxicity, and pancreatitis that can occur. However, with your TPMT, this can put you at a higher risk nonetheless. Um, there's non-melanoma skin cancer, but let me speak to that on this slide. So the malignancy risk, essentially, you are at risk of developing, or one is at risk of developing non-Hodgkin's lymphoma, hepatosplenic T-cell lymphoma, as well as your primary lymphoproliferative intestinal disorders. Non-melanoma skin cancer is also been recorded, and it is quite important to note that even after stopping thiopurines, there is an increased risk of developing this despite not being on the drug. So what this means is that you do need to monitor and see if these patients do develop this despite not being on the treatment, excuse me, and urinary tract cancers can take place as well. With patients that are at increased risk of developing malignancies are usually patients of the age of 65 and young patients who with negative IgG serology to EBV. So these patients, essentially, once you start them on treatment, they have been shown to have an increased risk of developing malignancies, and therefore, if they fit in this criteria or category, rather not use it. In terms of pregnancy and lactation, the drug has been shown to be continued if used as monotherapy. However, if it has been used with your anti-TNF, it is been advised to rather stop it, but it needs to be looked at an individual or individualized basis, essentially. So in Crohn's disease, so thiopurines in Crohn's disease, there's Cochrane analysis of aminosalicylates as well as 6-mercaptopurine in Crohn's disease. And essentially from active disease to remission, the rate of 47% versus 37% is seen, with the odds ratio response increased after about 17 weeks of treatment. So overall, essentially, 50% of patients may respond to therapy, but once in remission, about 50 to 60% of these patients will maintain that response. So the problem is that, if you don't see any sort of response in about 3 to 4 months' time, one needs to perhaps test the metabolite levels and see if you can increase the metabolite levels with the help of things like allopurinol or what have you. But this access is a little bit limited in a lot of our facilities here. Like with our trials that I spoke about before, two important trials that one must think about when thinking about thiopurines is your SONIC trial as well as your SUCCESS trial. So your SONIC trial essentially took about 500 odd patients on thiopurine and biologic naive, which we'll be hearing a lot about in the next talk of advanced therapy. But essentially, they looked at moderate to severely active disease patients, and they found that the use of a combination of these drugs rather than individual was good. So biologic as well as the use of thiopenes was useful in the clinical efficacy as well as endoscopic healing. Also, with the SUCCESS trial, basically confirmed that the combination of, in this particular case, was infliximab and azathioprine was far superior in clinical response as well as endoscopic healing. However, in the BSG 2025 guidelines, what they have summarized to say is that it's not really suggestive, like we said in monotherapy, in induction and maintenance of remission in patients with moderate to severe Crohn's disease. However, can be used in other circumstances, as which we've spoken about now. Thiopurines and ulcerative colitis, not much data to support the efficacy. However, there were about 4 randomized controlled trials that Schlesinger spoke about that were small and reached different conclusions, which put a little bit of a span in the works. There was some subset of patients with severe active UC who maintained remission with induction of cyclosporine and was bridged over to azathioprine, which showed that there was decreased rates of colectomies. However, what BSG has said is that BSG 2025 said is that purine analogs are not suggested for induction or remission, but are suggested for maintenance of remission in patients with moderate to severe UC once remission is achieved. When withdrawal of purine analogs as monotherapy or combination therapy are looked at, there is a risk of relapse, so one needs to be quite careful when looking at that. So we've covered aminosalicylates, we've covered our glucocorticosteroids, we've covered our thiopurines, and now we're looking at methotrexate. So methotrexate, cytotoxic, basically in the inhibition of dihydrofolate reductase. It inhibits pro-inflammatory cytokines, and it increases the production of regulatory cytokines. So in Crohn's disease, there are large randomized control trials that look at methotrexate subcut compared to placebo with with tapering steroids, and they found that 39.4% of patients assigned to methotrexate achieved remission of prednisone compared to 19.1% of placebo. And follow-up studies were done thereafterwards with lower doses of methotrexate given at around week 40, they found that 65% of patients were still in remission. So therefore, methotrexate at inducing and maintaining remission was seen to be quite good in Crohn's disease. And to note that with methotrexate, like in your sulfasalazine, you need to be giving folic acid. And note was made that it's obviously not suitable in the use of in pregnancy. With UC, also lacked a little bit of data to prove the efficacy of the treatment of active UC. There are these 2 trials that I could find that I thought were important to mention. So the Meteor trial, which basically compared steroid-dependent UC patients on methotrexate versus placebo. And they actually found that there was no statistic significance in steroid-free remission or endoscopic healing. However, patients were more likely to be in clinical remission on methotrexate. Then Merit UC trial came along and basically proved that there was really no difference in active treatment and placebo. So basically, the BSG guidelines then said not really suggested in moderate to severe UC. Just to hop on again, essentially Crohn's disease, not for monotherapy, with methotrexate, and then with ulcerative colitis, not really for induction and maintenance. However, if one is considering methotrexate, the concept is to start slow and go up slow, and to not initially worry about the liver functions, but obviously to monitor it. But yeah, this is essentially what BSG speaks about methotrexate. Then we come to CNI, so calcineurin inhibitors. Just to touch on it, it is in Schlesinger as well, so I thought maybe just to mention it. But cyclosporin, as we've probably seen, is more used in acute severe UC patients, essentially helping to bridge over to immunomodulators, but not much role in Crohn's disease. In terms of tacrolimus, also, it is absorbed more reliably than cyclosporine, but there are trials that essentially spoke to this as well. But the issue with tacrolimus, as one can imagine with our hepatology, is that it has toxic effects and side effects which are challenging to manage. There was one RCT essentially in from Schlesinger that spoke to a study with UC patients of 63 Japanese patients, and they find that higher trough of tacrolimus levels had better sort of response and non-significantly higher rate of remission compared to placebo. But in Crohn's disease point of view, there was an RCT that showed efficacious healing of perianal fistulas in Crohn's disease. Having said this all, it is quite difficult to manage, especially when we have other options available. It's not commonly used essentially for these situations. Obviously, if there are the needs, the option is available. Then alternative immunomodulators that were mentioned were MMF, as well as thalidomide. Not much has been gone into it, especially because we have superior agents like azathioprine, where there was a pilot study that basically looked at comparing steroids on azathioprine versus MFF, and it basically showed that azathioprine was more superior. So with the side effects of MMF on board, it was not suggested to be used. And then thalidomide, essentially the same sort of case. So in terms of drug therapies and our conventional therapies, we've essentially covered all the topics. What I tried to also go through is in Schlesinger, it was nice under the chapter they spoke about a few other things. It's not really conventional therapies, but I thought I'll just speak to it so that when you do read it, it becomes relevant. But adjunctive therapies like antidiarrheals, anticholinergics for alleviating diarrhea and cramping. Obviously, this is definitely not in an acute setting, but in a patient that's in remission or doing quite well, these are drugs that can be used. Patients who have had surgeries or ileal disease, not to forget about supplementation like your vitamin B12, as well as patients who have bile acid, assault, diarrhea, the cholestyramine, however, with many problems in its own as a drug, just to think about it, as well as iron supplementation, especially in those with resections that have been done before. Then there was a topic on or section on antibiotics and probiotics. As we've seen with a lot of the Crohn's disease realm, there's a clear role in treating our pyogenic sort of complications of Crohn's. So antibiotics that were recommended there are your metronidazole, your ciprofloxacin, your rifaximin. Not really much in UC. Probiotics, even in our BSG guidelines, also doesn't really speak too much to any clinical benefit and not really recommended. And then the last sort of section that was in Schlesinger was the nutritional therapy, basically talking to ulcerative colitis, in that TPN hasn't really much of a role as a primary therapy, rather bowel rest and IV steroids as we do in an acute setting, versus Crohn's disease, where TPN is proven to be effective, especially in the short-term therapy for severe sort of luminal and perianal disease in combination with bowel rest. So I just thought I'd mention that because it was in the chapter, and it does speak to it in our BSG guidelines. So just to conclude, sorry that I have taken a bit of time, but essentially there's a couple of drugs that are still effective, especially in this new era of advanced therapies and biologics. And we're finding that our conventional therapies essentially now can add on to the advanced therapy and is also proving to still be quite useful. So, I look forward to our talk in 2 weeks' time to see how this ties in quite nicely, so that we can treat IBD effectively in the future as all of us as future gastroenterologists. Thank you very much. So, like I mentioned, a lot of the information was from Slazenger as well as our BSG guidelines. Yeah, thanks, Prof.
Thanks, Midhun. That was an excellent, excellent overview. So, are there any questions from anybody in the audience? I don't see anything on the chat.
Yes, I'd like to ask a question. Good evening,
Yes,
everybody.
yes,
I just
please,
wanted
go
to
ahead.
ask, I just wanted to ask, so in a patient that comes in with active Crohn's disease, in summary, which two drugs would we give for active Crohn's? And then the other one that comes in, I know it depends with ulcerative colitis, it depends on the severity.
Midhun, are you happy for me to answer that?
I mean, like you correctly said, in ulcerative colitis, it is obviously your steroids that you would think about, depending on obviously your true Loveridge criteria. You put them on IV steroids. That's that. With Crohn's disease, also if it is active, it depends on the presentation. Prof, obviously you must add to that, but it depends on the presentation. If you've got your abscess formation or collections or what have you, you have to look at that and decide on therapy from there. So it really does depend on the presentation that they come with. Steroids is useful in my mind at least. But yeah, Prof, there afterwards, I mean, maybe you can.
Yeah, so with active Crohn's disease, it very much depends on what you're talking about. Is this isolated terminal ileal and cecal Crohn's disease? Is this ileocolitis? As Midden said, is there perianal disease? Are there collections? So, for example, straightforward ileocecal Crohn's disease, which is uncomplicated. This is where ileal release budesonide intracort would be the treatment of choice if it's mild. If there's more extensive disease or the patient is sicker, then you're probably going to move on to a systemic corticosteroid. As Midden alluded to, we don't go above 60 milligrams per kilogram, sorry, 60 milligrams a day. It's generally 1 milligram per kilogram, but for example, if you've got an 80 kilogram man, there's no point going up to 80 milligrams. And corticosteroids should be used for the shortest time possible and weaned as quickly as possible. In most first world or high resource countries, generally because of the availability of advanced therapies, they tend to wean their corticosteroids very quickly. But we go a little bit slower in our unit. We go down by 5 milligrams a week, which usually takes about 3 months. The reason for this is because somebody with Crohn's, I believe, once they've needed to have systemic corticosteroids, they really should go on to a steroid-sparing agent, which in our setting is typically azathioprine, 6-mercaptopurine, or methotrexate. And these drugs take some time to work, which is why I prolong the steroid course to give them time to kick in. Of course, this would all depend, and we're going to hear about advanced therapies next week. So I'm not going to chat too much about that. But essentially, if you lived in a resource-rich setting, azathioprine, methotrexate, and 6-mercaptopurine are not really treatments of choice any longer. Their role is largely in combination, particularly with anti-TNFs to reduce immunogenicity. They're not really used in combination with any of the other newer biologics because they have very low immunogenicity and antibody formation. In terms of ulcerative colitis, as Midden alluded to, it depends very much on the severity. Acute severe ulcerative colitis is a talk entirely on its own, and I believe it's been covered. More mild to moderate disease, your 5-amino salicylates are your first-line therapy. Anything that extends beyond the rectum should receive oral and topical therapy. And we tend to use pentasa suppositories, one a day when the patients have active disease. As they go into remission, we tend to cut down to sort of one every second day or one every third day, just because patients hate taking suppositories. So there's very poor compliance. And again, between 2 to 4.8 milligrams, grams, depending on the severity of the patient. And then again, with ulcerative colitis, I'm usually happier to, what was I going to say? Yeah, anyway, yeah, does that answer that?
Yes, Prof, it does. Thank you. Thank you very much.
Okay,
Thank you.
so there's some questions in the chat. Right, from Jack. Thanks for a great presentation. Could you comment about clinical and biochemical monitoring for patients on azathioprine, considering therapeutic drug levels are not commonly monitored? So great question. So we do not have the availability of therapeutic drug monitoring in South Africa, and I'm not sure if it's available anywhere else in Africa. So this limits us somewhat in pushing around with doses too much. In our unit, we use a lymphopenia and a raise in the MCV as markers, surrogate markers that you're looking at therapeutic dosing. Just to point out, allopurinol, I don't recommend it unless you have availability of therapeutic drug monitoring because it can cause a profound neutropenia. So you really need to have this in expert centers where you can do a therapeutic drug monitoring. Okay, VG, do you routinely supplement IBD patients with calcium and vitamin D, especially if starting with corticosteroids? Absolutely, 100%. It's a knee-jerk reaction in all of our patients to have calcium and vitamin D when they're on steroids. And in fact, we have a very low threshold to have most of our patients at least on a vitamin D supplement. Surprisingly, even despite the amazing weather that we have, a cohort study from our unit showed that many patients were still vitamin D deficient, and vitamin D has a lot of immunoregulatory properties. We also have a low threshold to have patients on calcium supplements, particularly in those patients who've required multiple courses of steroids, or women or people who are at risk of osteoporosis. And then BG's other question, routine use of sunscreen for patients on azathioprine, 100%. 100%. If patients can afford it, which unfortunately in state practice we can't offer it to them, and we know that sunscreens are actually extremely expensive for some inexplicable reason. Just to point out the risk of non-melanoma skin cancer, Midhun did allude to this. It remains lifelong for patients who've been exposed to thiopurines in the past, even if it's discontinued. The opposite is true of lymphoma. The risk of lymphoma once you stop thiopurines reverts back to normal. So it's the opposite of non-melanoma skin cancer. Other questions, guys? Okay, so I just wrote down a few points. We've got a few minutes. So although 5-amino salicylates don't work in Crohn's disease, essentially they're pretty homeopathic, but it did allude to the fact that they may have some benefit in Crohn's colitis. So this is the only time that I would use a 5-ASA in the setting of Crohn's and only for Crohn's colitis. And just to mention that 5-ASAs act topically. Okay, so don't give them in someone who's got a stoma to treat more distal disease because they're just going to come out in the stoma bag. Cilazapyrin, as we know, it's not the greatest drug because it has lots and lots of side effects. So if you have access to other 5-ASAs, I must say I would use them, the mesalazine preparations above cilazapyrin, unless there's another indications like an arthropathy, a rheumatology complaint where, as we know, cilazapyrin is an excellent choice. One other point about the 5-ASA formulations, people have diarrhea. Their stool is often very acidic. Okay, so you find that, for example, Asacol, which requires a higher pH before it's released, is not actually dissolved, and patients will complain that they're finding solid tablets in their stool. And here, pentazim may be a somewhat better option because it is released more uniformly and not really pH dependent. Okay. A couple of things about corticosteroids. The ileal release budesonide is really only for ileocecal Crohn's disease. It's not for ulcerative colitis. Okay, it doesn't get to the colon. An exception to this is a formulation which is called budesonide MMX. So very much like the 5-ASA that we talked about, Lialda. This is budesonide in an MMX formulation, which allows it to be released in the distal colon, which means that it's actually pretty good effective therapy for left-sided UC. But as far as I'm aware, it's not available anywhere here in South Africa. Corticosteroid enemas, yep, great choice for patients with left-sided ulcerative colitis because they can get all the way up to the splenic flexure. Okay, the one problem I have with them, because we don't have the foams, which are much better, is that they often bypass the rectum. So for patients with severe proctitis, they often continue to have symptoms despite the enemas because of the proctitis. And this is not evidence-based, so please don't use it as being evidence-based, but it's just, I found it very useful in my clinical practice. I give a Sherry-Proc suppository for 2 weeks that contains a little bit of steroids, and often it gives patients with symptoms of proctitis quite a lot of relief because they suffer from tenesmus and urgency, which are arguably two of the worst symptoms that patients with ulcerative colitis suffer from. Okay. Just in terms of the TPMG genotype, which we have available locally, elsewhere in the world they can do the phenotype where they can actually measure the levels, but we don't have that available to us. So the TPMT testing that we do only measures 2 specific mutations. And just to point out that there are other mutations in the TPMT gene that can cause neutropenia. So even if you've got a TPMT negative patient, this does not circumvent the need for ongoing monitoring of full blood counts, particularly the white cell count. All right. In terms of methotrexate, I didn't have much to add to what Midhun said. I think that was a perfect overview. Of course, in Crohn's disease, it wouldn't really be my first choice if I had access to other therapies, but we do use it. No use in ulcerative colitis. Unless you've got absolutely nothing, then it's probably worth a shot. But just to mention, please, that if you are going to put a woman of childbearing age onto a methotrexate, I'd advise you strongly to get them to sign an informed consent because accidents happen and patients can often have quite short memories. So just to protect yourself, just make sure that you've got some record that you have actually explained these risks to the patients. Okay, one last. Please, can you comment on drug preferences for extraintestinal UC manifestations? I've mentioned the methotrexate and cilazapyrin are good. Obviously, if you've got rheumatological complications. The rest of the options really fall under the advanced therapies, which I'm sure we'll discuss in 2 weeks' time. Okay, any other questions or comments? Okay, well, we're almost out of time. VG, yeah, go for it.
Hi, Jill. Sorry, I didn't want to
Hi.
chat. You were speaking about like monitoring the like an FBC on patients on ASA. How
Yes.
frequently do you recommend for the audience? I mean, obviously, when you're starting them on treatment, you want to do it within
Yeah.
a fortnight, and then every time you increase it, of course. But once you have the
Yes.
patient on a stable, like in a dose, how frequently?
Okay, so for the
you want
first couple of years, I must say I do 3 monthly, a full blood count, diff, and LFTs. And once patients, I've got patients who've been on azathioprine or 6-MP for years, and they've never had a problem. And then I'll push them out to 4 months and even 6 months. But just remember, this can happen years after patients have been on thiopurines. I've had it in patients who've been 10 years stable on a thiopurine and suddenly dropped their white cell counts. So, never ever just rest on your laurels there. Very, very important. This is unlike pancreatitis, which wasn't mentioned. That usually occurs within 3 months of commencing. So that's a side effect that's pretty, if it's going to happen, it's going to happen more acutely.
we've seen a few over the years. Of course, if you use azathioprine, you will see a case of acute like
100%.
pancreatitis,
Yeah.
and it usually happens early on. It's usually within that
It always
first
happens
week
early.
or
Yeah.
something like that. Yeah.
Absolutely. Absolutely. Okay, and then just the one last point that I jotted down, which I didn't mention, well, I don't think I did, because I seem to have been talking a lot, is in patients with acute severe ulcerative colitis, if they haven't been on a fiber minus salicylate, do not start it during their admission when they're on IV steroids, because there's about 5% of people that have a paradoxical reaction. So they actually get diarrhea from the 5-ASAs, and that's completely going to mess your decision making up. Of course, when they're discharged, then one must start them on a 5-ASA. If they've been on it all along, well, that's fine. Then you continue. Any other questions, comments before we wrap up? Okay, so in that case, thanks everybody, and particularly thanks to Midhun, who gave a fantastic presentation. That was absolutely outstanding, really. And our next session is on the 17th of November, again at 6 o'clock. I'm also going to moderate that one, and our presenter is going to be Pascal. And with that, have a good evening, everybody, and I hope you all learned something, and we'll see you in 2 weeks' time.
Thank you, Prof.